very important to emphasize that in the epidemiology on this is that people that have premenstrual dysphoria have no higher rates of Axis II disorders. It doesn't seem to be related at all to issues of character or personality style, anything like that. And it's unique in that it occurs with great regularity. If women have their period on a regular basis, they can say, hey, this Thursday it's going to hit, or Friday. And for some women, it's just 1 day a month. And for some women, it's 10 days a month. But within each individual woman, it tends to be about the same number of days each month. It's also characterized as abrupt onset, abrupt offset, within hours getting depressed, within hours having it go away. Totally different than any kind of other mood disorder, okay? And it's the only mood disorder that responds to antidepressants within hours. Premenstrual exacerbation of major depression, even if people are not prone to PMDD, if they're in the throes of a major depression, it's not unusual to have some increase in depressive symptoms premenstrually. And so this is generally dealt with pretty successfully by either adding an SSRI, or if they're on an SSRI, is bumping the dose up a little bit. So like if they're on 20 milligrams of Prozac, you bump it up to 10 milligrams of Prozac or something like that during that period of time that they have increased symptoms. 90% of women who successfully commit suicide, it's done premenstrually, so this can really throw gas on the fire with depression. It's always best to try non-pharmacological approaches if that works. Reducing caffeine and alcohol almost certainly has a lot to do with just improving the quality of sleep, which clearly has a lot to do with mood regulation. Exercise as well. The serotonergic antidepressants. Now this is really any antidepressant except Wellbutrin could be used. This is the one depressive disorder that, I mean, this is not speculative, this is really just a fact, is due to a significant, abrupt decreased availability of serotonin. Okay, so those are the drugs that work. And if you use drugs that don't target serotonin, they're no better than placebo. There are case reports of St. John's wort being effective, but there's no hard data about that. Okay. It's got to target serotonin, intermittent versus continuous. If the woman only has it for this discrete period of time, 4 days a month, then they can either start taking it the moment they start feeling depressed. Also, frequently, I should say that it's depression, but it's often accompanied by either some irritability or anxiety mixed in with that. Or if they are highly regular and they say, yeah, it's going to happen on Thursday, they can start taking it on Wednesday. And it's probably better to use a short half-life drug. You can use Prozac, but it'll stay in your system long. But the obvious advantage is that you don't incur the side effects you do, like emotional blunting or sexual dysfunction or what have you, if you just take it 4 days a month. Continuous would be if people that have ongoing depression, but they just have a bump up in depressive symptoms premenstrually. And actually starts working in a couple of 2 or 3 hours. And really, the time frame for onset of symptom reduction really closely parallels when reuptake inhibition starts. Okay, so let me give you sort of a theory about this. And by the way, this is my my Prozac cup. My mother gave me this. She thought I needed it, so I feel better already. Okay. Anyway. Even when people have a so-called reactive depression, let's say something happens that's horrible, like a death of a child, for instance. Okay, there are acute onset, severe mood changes, and most of the time it's grief. And of course, it can deteriorate into major depression. So there's abrupt changes in mood, but some of the more hardcore biological symptoms of depression, like pervasive anhedonia, severe sleep disturbances, weight loss, don't happen immediately. You may get some initial insomnia, but this early morning awakening, that doesn't happen immediately. And what's presumed to happen is that over a period of probably weeks, as the depression sort of heats up, is you start getting changes, not just at the level of the synapse, but in the internal chemistry of the cells. And then when you use an antidepressant, it immediately blocks reuptake within a few hours and restores normal amounts of the neurotransmitter, but it takes also days to weeks to have that get back on track. But here we have a disorder. It doesn't have anything to do, or at least theoretically, but my money is on it, this is correct, with there being these massive changes in internal chemical microenvironment of the cell. It has to do with within hours you don't have any serotonin, okay? Or you have a little bit, okay, but you don't have as much. Now, what is going on here? All right, there are two theories, and one of them is this, and these are not just made up. I mean, there's data to support this. There is an enzyme, there's a gene that makes this enzyme called tryptophan hydroxylase. And what appears to happen in women who have premenstrual dysphoria is when they enter this phase of their cycle, it causes gene silencing. This gene gets shut down big time. Maybe not completely, but it's not available. And in order to make serotonin, you have to have tryptophan, the amino acid, and then tryptophan hydroxylase converts that into 5-HTP, which we'll talk about later, which is then immediately converted into serotonin. So you take the enzyme out, and you can eat a ton of tryptophan. It won't make any difference. You can't make it. Okay. So there's something about the SSRIs that reactivates the production of this normal enzyme that converts tryptophan into serotonin. The other thing is, I want to show off here, I've learned how to pronounce this word, allopregnanolone, and this is a steroid hormone. Steroids are made from cholesterol, and it's made in the brain, and it says potent GABA-A agonist. Next class, we're going to talk about anxiety disorders and the GABA system. Well, you probably remember this from the first class. Remember that the most common inhibitory neurotransmitter in the brain is GABA, okay? And an agonist turns something on. So when you have this naturally available, as everybody does to some degree, it's helping to dampen down the brain. Okay, it's like a natural endogenous tranquilizer. Okay, and so it says low levels in people with major depression, as measured in the cerebral spinal fluid, and it normalizes when the depression gets better. So there's some relationship to that. But marked reduction of this molecule in premenstrual dysphoria and a rapid increase of it with SSRIs. And so this is probably what accounts for the common anxiety that oftentimes will go along, with the depressive symptoms of premenstrual dysphoria. Okay? Now, here, two studies, okay, double-blind, placebo-controlled studies, collapse the data, and you have taking 1,200 milligrams of calcium a day, which is the equivalent of 4 Tums. You get 55% improvement with Tums versus 36 with placebo. Now, it's probably not a bad idea to get some extra calcium, especially if you're a woman. But I have to caution you that both of these studies were sponsored by the makers of Tums. So, take that with a grain of salt.